Everybody, welcome back. This is breakout session B, centering equity in our public health tools and framework. The description of this session, it's going to highlight state examples to advance internal organizational change efforts that prioritize health equity in the center of all our processes and outcomes, and clearly define measures of success and foster transformation within state and territorial public health agencies. So hopefully you're in the right breakout. I'm going to be introducing our three speakers for this afternoon. I'll be moderating this session. What I'd like to do is to give the bio descriptions for all of our presenters at once, and then start the presentations, and each presenter will queue up the next presenter, so I don't have to keep interrupting. So I'd ask that if you have questions, please submit those for us, and they will be handled at the end. So some housekeeping announcements for you. We're in listen mode only. Closed captioning is available. This session will be recorded and posted on the virtual platform. Please hold your questions until the end. So as the moderator, I can ask those all at one time. And the session materials and the full bios of our presenters are located in the resources tab. So I'm ready to begin. And I'm going to be starting with Dr. Monica Burrell, who is Commissioner for the Massachusetts Department for Public Health. She was appointed by Governor Charlie Baker in 2015. Commissioner Monica Burrell serves as the Commonwealth's chief physician. She's dedicated to reducing health disparities and developing data-driven, evidence-based solutions for keeping people healthy, and is helping lead the state's aggressive response to the opioid crisis. In 2017, Massachusetts was among few states to see a reduction in opioid overdose deaths, thanks to a variety of new programs and initiatives. As commissioner, Dr. Burrell oversees a public health workforce of nearly 3,000 and an expansive department that addresses issues from environmental health to injury prevention and infectious diseases. In 2017, Massachusetts was named the healthiest state in the nation by America's Health Rankings report. Dr. Burrell is a board-certified internist who has practiced general internal medicine for more than 20 years and has been recognized for her dedication to underserved and vulnerable populations. Prior to becoming commissioner, she was chief medical officer of Boston Healthcare for the Homeless. She holds a master's of public health degree through the Commonwealth Fund and Harvard University Fellowship, and a medical degree from Boston University School of Medicine. Our second presenter, Dr. Earl Benjamin Robinson, is Director of the Office of Community Partnerships and Health Equity at the Louisiana Department of Health. Dr. Earl Benjamin Robinson is the Director of the Office of Community Partnerships and Health Equity at the Louisiana Department of Health. He leads, develops, and oversees health equity and community partnership efforts that support Louisiana's health and wellness. While also leading these efforts, he's intentional in creating fair and just opportunities for all people to reach their full health potential. In 2019, Dr. Benjamin Robinson led the development of the first agency-wide health equity plan at the Louisiana Department for Health. It's the first plan of its kind in a southern state. Dr. Benjamin Robinson is a public health practitioner with over 19 years of experience and is faculty at Xavier University's Public Health Science program. Since 2015, he's been distinguished by the American Psychological Association as a health equity ambassador and is a practitioner scholar member of the Health Disparities Education Awareness Research and Training Health Equity Scholars, and is the co-founder of the BOT Group, a population health consultation firm. Lastly, Dr. Benjamin is a National Advisory Board member of HealthLink, is an alumnus of Loyola University in New Orleans, completed postgraduate work at the University of Mississippi Medical Center and Johns Hopkins University, and is a Doctor of Health Science graduate from Nova Southeastern University. Dr. Karan C. Patel, College of Health Sciences. Christopher Asura is co-director of the Health Equity Institute at the Rhode Island Department of Health. Christopher Asura is the co-director of the Health Equity Institute at the Rhode Island Department of Health. And in his role, Chris oversees the teams responsible for implementation of the Health Equity Zone Initiative and the Rhode Island Department of Health's partnership with the Rhode Island Office of Medicaid to improve the social and environmental determinants of health by establishing meaningful community clinical linkages. He has been with the department since 2011, and he brings to his role a diverse background of prior experience in banking, hospitality, and construction. So won't you help me welcome all of our presenters this afternoon. Please welcome Dr. Burrell. Laurel.
Thank you so much, Vivian, and thank you all for being here. I feel privileged to be a part of this esteemed panel and excited to talk with you all this afternoon. So I'm really going to focus today about talking about our focus on equity and some specifics related to our COVID-19 vaccine rollout in Massachusetts. And I'm going to do this so that we can take these concepts of equity, and I can talk a little bit about how we at the Department of Public Health in Massachusetts have been building a framework of equity for many years now, and give you specific examples related to COVID-19 of the use of that framework. So first, the three pillars of our vaccine effort are to preserve life, preserve our healthcare system, and reach our most vulnerable populations. So equity is at the core of all of our vaccination work. This is in line with our overall approach and commitment to equity within the Department of Public Health in Massachusetts. In my 6 years as in the department as commissioner, we've framed our work based on what I call a precision public health model. So this is really about using the data that we already collect to better understand the social determinants of health and highlight data disparities for targeted interventions of our limited resources. In fact, 6 years ago, we created an Office of Population Health that directly reports to me to propel this work forward. We also created a linked data warehouse, first of its kind in Massachusetts, accessing data throughout state government to inform health outcomes. This approach has highlighted that certain populations, for us, we found that communities of color, individuals with a history of incarceration, housing instability or homelessness, substance use disorder, or mental illness have a heightened burden of illness regardless of the disease. In Massachusetts, we now view our programs and policy work through this health equity lens. We've flipped our model from looking at specific diseases and conditions to the populations impacted by these compounding social, economic, and health factors. We use this framework also for our racial equity work, including our racial equity data roadmap, which looks to improve our ability to capture and analyze data on demographics, including race and ethnicity. This existing framework was very important for us and served as a foundation for our equity work related to COVID-19, which has put such a horrific spotlight on existing health inequities, including inequities in our communities of color. Since the start of the federal vaccine distribution, when we knew supply would be extremely constrained across the country, we focused on how to distribute our limited vaccine in a fair, ethical, and transparent way. In Massachusetts, I'm proud that the decision was made early on to first vaccinate all healthcare workers, not just clinicians. We based our recommendations on the national academies and ASIP and others, and went further by prioritizing all COVID-facing health workers, not again only the healthcare professionals, but also healthcare food service workers, facility workers, interpreters, and others. Similarly, as our first priority, in our first priority group, we prioritized home health workers, including personal care attendants, with this prioritization, recognizing their important role providing services to vulnerable homebound individuals, and the fact that we found they often reside in communities highly affected by COVID-19. I'm proud that we also prioritized congregate settings, including prisons and jails, making sure not just correctional staff, but inmates were offered vaccine in our first phase of vaccine prioritization. We were among only a handful of states to initially include homeless shelters and domestic violence shelters in our earliest prioritization. To me, it's really about balancing the efficiency with a conscious dedication to equity, which both are critical. In Massachusetts, we just passed the 2 million mark for the number of people fully vaccinated out of a population of about 7 million. And as of Monday, all individuals above the age of 18 are now eligible for COVID-19. That's about another 1.7 million people. So we know it'll take some time to get everyone vaccinated, and we'll continue our efforts knowing that the demand for vaccination in Massachusetts remains very high. Because on this panel we're speaking about specific public health tools, I'd now like to provide you with just a few quick examples related particularly to our COVID-19 and vaccine work. First, I want to talk about our Health Equity Advisory Group. Early on in the pandemic, back in the spring of 2020, we recognized these disturbing inequities, which now we've all heard about, in who was being infected and getting sick from COVID-19. As you may know, Massachusetts was one of the states where we had an early spring was our first surge of COVID-19. In May 2020, we assembled an external health equity advisory group to advise me and my staff in providing timely and actionable recommendations on way that COVID-19 was having a disproportionate impact on key populations, including those who have historically been underserved and marginalized. These recommendations have informed our COVID-19 response and have been central in improvements we've made in how we report and stratify data, how we address the needs of priority populations, such as some of those I mentioned earlier, and our COVID mitigation work. And now this group has continued to be a touch point for us as we move through vaccine deployment and rollout, and how to do that equitably. Second example I want to give you is our COVID-19 Community Impact Survey. In the fall of 2020, we deployed a statewide community survey to better understand in real time the immediate and long-term health impacts of the pandemic, ranging from access to testing and delays in healthcare, access to housing, food, safe working conditions, and other factors contributing to increased COVID burden. We engaged a network of community partners to intentionally reach minimum numbers of respondents from highly impacted communities that we don't often hear about in surveys. Those included, but were not limited to, our LGBTQ+ residents, residents with disabilities, residents experiencing homelessness or housing instability, and our residents in communities of color. We had more than 33,000 people respond, allowing us to better understand the unique needs and experiences of these priority groups. And it was really important to us to incorporate community organization feedback in the development and deployment to reach groups. And these community-based organizations really helped us engage individuals so that we could better and fully understand what was going on. From our initial analysis, we saw what we see in many of our analyses, that many of the groups disproportionately affected by the virus itself also face disproportionate consequences of the pandemic in other aspects of life critical to health and well-being. For groups experiencing the greatest inequities across all the topics in the survey, this included areas such as workplace environment contributing to an increased COVID-19 risk, lack of access to critical health information in their preferred language or location, economic hardships and food insecurity, and limited access to telehealth due to limited broadband or equipment. We have detailed information on what subgroups within our populations were affected by each one of these areas and others. And you can find those community survey results online if you'd like to dig further. But suffice it to say, in my short time, I'd like to really emphasize that all of these survey results are being used to prioritize resource deployment and address the inequities created and exacerbated by the pandemic. And the results and the way that we did the survey with community involvement and community engagement has really empowered us to better serve our communities. The next thing I want to talk to you about is our statewide public information campaign. In the same way that we did the survey, we did this by engaging our communities and getting feedback and doing research on what would be the best way to get information out to communities. We call our campaign the Trust the Facts, Get the Vax, and it's really based on this extensive insight from individuals and survey done around Massachusetts residents on what their motivators are to get vaccinated, what are the barriers, and where do they get the information, et cetera. As an example, one of the most trusted voices was said to be physicians that they know and recognize from their community. Those are at the top of the list. So we developed a PSA in English and Spanish, featuring a diverse group of doctors who represent a wide range of races, ethnicities, and regions in Massachusetts to really talk about what the facts are about vaccination. And as an example, one physician told us that she has heard directly from patients who decided to get vaccinated after seeing her on television speaking about the vaccine. The last initiative I want to tell you about, in some ways, really the most important example of our precision public health use is our new initiative, health equity initiative in 20 hardest hit communities in Massachusetts. We've launched this new equity initiative in line with our data-driven DPH approach to precision public health. So what we did, this initiative is focused on 20 hardest hit communities. It includes giving them enhanced assistance, support, resources, with the goal of not only building trust in vaccination, but also improving access and increasing vaccination to remove barriers that keep people from getting vaccinated. So going back to where the data leads us, we looked at the municipalities in Massachusetts with the greatest COVID-19 case burden. Professor Kennedy was talking about this earlier, right? So where are the greatest number of cases? Taking into account then social determinants of health, looking at the CDC SVI index, and disproportionate impact of COVID-19 on our communities of color. This resulted in 20 municipalities to focus our health equity initiative on related to vaccination. And this approach explicitly acknowledges and begins to address both historical trauma and continued distrust of communities that have been marginalized in our society, and that access needs for these communities might not be met through existing channels. Again, this initiative, this initiative is funded by $27.4 million in CDC funds, and it brings resources directly to the community so that they can do hyper-local approaches and engagement with their individuals and communities. And we are actively listening to each community and building really localized responses to what they need to strengthen their vaccine programs and awareness. We've paired each community with a Department of Public Health community liaison who works directly with local boards of health, community health centers, provider groups, and community and faith-based organization. And we're really putting individuals on the ground, local residents hired to do neighborhood activities like door knocking, meeting people where they are in supermarkets, barber shops, and corner groceries to offer information, answer questions, and help them get access to the vaccine. I meet with the mayors of each of these communities, and we've presented them with customized data on where the penetration rates by race and ethnicity, age, and gender are lower than state averages so that they can, again, target their resources. All of this work is based on two principles: using data to inform evidence-based resource allocation and including the narrative of the community. So we're engaging those we're trying to reach and asking them what they need without assuming we have the answers. And related to data collection, I've put out 2 orders now, one related to COVID cases and deaths, and one related to reporting related to vaccination, requiring demographic reporting, including race and ethnicity. And after those public health orders have gone out, we've seen a marked increase in the data that we receive. Because as a core to all of these examples that I've given you is having the data to understand what our baseline is so we can make these improvements. So of course, there's much more work to do. We've made progress and we continue to learn along the way. Meanwhile, we continue our data-driven precision public health approach to ensuring every person in Massachusetts who wants a COVID vaccine can and will get one. Health equity, and specifically racial equity, was the cornerstone of our work before the pandemic, and will continue to be our cornerstone in the post-pandemic world, where I hope we can learn many lessons from the pain and suffering of the pandemic and continue our progress toward creating more fairness and justice in health. That's my personal mission and the mission of the Department of Public Health. As Professor Kende said earlier today, when we work on health equity, we improve health for all of us. Thank you very much, and now I'll pass it on to Dr. Benjamin Robinson.
I have to remember to turn my cell phone sometimes. Thank you so much. That was a beautiful overview of the work that you guys have done in relationship to being more equitable, providing care to COVID, to those suffering from and affected by COVID. I am Earl Nuptius Benjamin Robinson. As has been stated previously, I am the director of the Office of Community Partnerships and Health Equity. It is an office that is about 2.5 years old. And our work is centered in operationalizing health equity on an agency level for Louisiana, inside the Louisiana Department of Health. And so before I get started, I would like to say that, health equity requires a tremendous amount of intentionality. Oftentimes when we hear people talk about equity, people are using words, but to the doctor's point, what you heard her talk about was a significant amount of intentionality. And that is a requirement when trying to understand or trying to mitigate that people are having different experiences. And in order for us to mitigate the fact that people are having different experiences, we have to understand that, and we have to devise plans to deal with that. We have to get to root causes. And so what my office has done or is attempting to do by implementing best health equity best practices and protocols is to operationalize that people are having different experiences. And as an entity that is responsible for providing services and care to people, we need to be aware of them, and we need to operationalize implement best practices and protocols that respond to people's social determinants of health. And as a result of that, I think that when we do that, we can improve our services, improve our professionalism, and also ultimately improve the health and the health of the people that we serve. And so when I came on board so next slide, please. And so when I came on board at the Office of Public Health, I had a responsibility of setting up the office and establishing a health equity plan. And so in coming into the situation, there was a consultant that had been hired to do some work inside the organization to assess people's awareness of cultural competency and to see how people felt about that. And so based on their findings, I was able to use that or lean into what was initially found in that person's work to understand that, I had to be mindful about how I needed to proceed in mapping out this plan of health equity and trying to implement new strategies and change culture inside an organization. Because as you guys know, culture eats strategy every day. Every single day we come into organizations who are wanting to affect change and wanting to have good intentions to make changes happen for the people that we serve. But at the end of the day, oftentimes cultures inside of organizations have the final say. And so I didn't want that to happen. I wanted to create plans and put actions into place that took into consideration what was happening inside the organization, but also took into consideration how to navigate inside those environments to ensure that the plans would live and that we could get from point A to point B and that we could do it under the umbrella of equity. And so I quickly, based on the findings from that evaluator, I realized that, to even say the word health equity was, in some people's mind, it was divisive because when they thought of health equity, they thought of black and white. And so what I quickly surmised was that, what I was going to do was develop a framework to move this work forward. And that framework was around that this was about building professionalism, improving professionalism of staff. And as a result of improving that professionalism, we would then be able to improve the services of the people that we serve. And then as a result of improving the services of the people that we serve, we would improve the health and the health outcomes of those individuals. And so learning about the organization that I was in, taking feedback from individuals, not placating to people's values, attitudes, and beliefs, but understanding the organization and knowing how to move, I thought it was best to create a theme or a strategy, a theme that would help to inform how this work was going to move forward inside the organization. And so with that, this theme, it was about, our framework would be about improving professionalism, improving services, and improving the health and the health outcomes of the people that we serve. And under this umbrella, we were able to move forward with pushing forward a process of implementing health equity. Because as I stated earlier, many individuals had these preconceived ideas that health equity was only a black and white issue. And so while we're in the process of providing training and education training and education to people to build their capacity to understand that health equity was more than, yes, it does include racial differences and as it relates to health, but it also can be about rural and metropolitan areas. It is about men and women's different health outcomes. It can be about a multitude of things. And so I didn't want people to rest there. And so by by creating this framework, this helped us to just give us the room to move and step forward to create a plan. And so our plan was centered around professionalism, improved services, and improved health and health outcomes of the citizens that we serve. And so it was rooted in that. And so as a result of that, we then were able to proceed to developing three factors that would then inform the strategies, the three strategies that would inform the action steps and recommendations that would outline our plan. Typically, when you look at health equity plans around the nation, oftentimes they're very obtuse and abstract, and they don't really tell anybody what to do. They just say, we're going to do this and we're going to do that, but they aren't very specific about who's going to do it. And so what I wanted to do was to create a plan that, one, took into consideration the environment in which individuals worked in, not placating to it, but just took into consideration that environment, but also gave very specific action steps and activities to the offices and departments inside that environment to move things forward so that we can start to affect culture change inside the organization. And so these were the three oval areas, were the three areas of focus that helped to, that we were going to be moving activities in. And so we were going to be focused on professional and behavioral actions inside the organization. We were going to be focused on organizational culture, focusing on those. We were going to be focusing on those organizational cultural activities that we could lean into to help move and change the culture inside the organization. And then we were also going to be focusing on organizational system factors, accountability factors that we could lean into to help support, one, staff behavior, but also to help ensure that those cultural changes that we wanted to take place will be moving forward. And all three of these factors would help, again, to map out what the strategies are, the action steps, and the recommendations are for our plan. And so the professional, organizational culture, and organizational systems, you will see later that became a part of our logo, and you'll see it in our logo. They became certain art symbols. Next, please. And so the first document, and so after we mapped out what our theme was going to be, improved professionalism, improved services, and improved health of the people that we served, and we knew that that was going to be our theme, and we were going to have three areas of focus that centered around staff actions and behavior, organizational culture change, and organizational systems change. We then developed our first document. And I think you guys have a copy of this document. The first document was called our Barriers to Health Fact Sheet. Now, initially I was going to call this our social determinants of health fact sheet. But the secretary at that time, and for very good reason, said, let's call it the Barriers to Health Fact Sheet. Because most people, when you think about, I mean, we all know what social determinants are. But a lot of people don't know what social determinants are. But when you say barrier, they know that. When you say health, they know what that is. And so this was our Barriers to Health Fact Sheet. This was our clarion call. This was the first thing that came out of my office. And this thing, it indicated three things. It indicated, one, that a health department can be, our system, our institution can be a barrier to the people that it serves. That was the first thing. Two, it indicated that many of the health issues that people are dealing with, they share barriers to health. They share them. They share, and some of the things that they share, poverty, lack of insurance, racism. So many of the social determinants are the drivers of health are shared with many of health priorities that are near and dear to us. And then three, those shared barriers, there are approaches that we can implement and use inside our interventions that we're using inside our organizations that are centered in social determinant of health approaches that we can incorporate into our interventions that we don't necessarily have to spend more money on, but we just need to be aware of. We need to be aware of, if we are providing STD services or obesity services, about the importance of creating safe spaces for people. We need to be aware of about the importance of making certain that our staff have proper training around homophobia or any inequities that are experienced in populations that we are serving. We need to be aware of, as health professionals, that housing is important and that job training is important. We need to be aware of those social determinants of health approaches and incorporate those approaches into our tactics and our health services. And that don't necessarily cost money. It just costs us being aware of those social determinants and using those approaches and partnerships to do our job better. And so this was the first document that we created. Again, it outlined that institutions can be barriers, that many of the health priorities that we deal with, they share social determinants of health, are barriers to health, and there are social determinants approaches that can be incorporated into the work that we do. We can, if you're doing an STD program, are you working with housing partners to make certain that individuals are have stable housing? Are you working with individuals to increase educational opportunities? Are you supporting individuals in making certain that they finish high school? These are things that, you know, that some people may feel live outside the health sphere, but when you incorporate this into some of your interventions, you help to stabilize a person's life and help to improve the possibility of them reaching their full potential, which has a multitude of positive outcomes from them. And so again, this was our clarion call document, and it outlined that institutions are barriers. There are many health priorities, share health outcome, means share determinants, and there are social determinants approaches that need to be leaned into no matter what intervention or services that you're providing inside your organization. Next slide, please. And so in developing so that next slide was the first document. And so this slide indicates those factors that I use to assess what was being done inside the organization to see where we were as it relates to health equity. Now, I must say that, you know, in our Office of Public Health, there were a lot of programs like the Office of STD, and the Bureau of Family Health that were doing a tremendous amount of work that were centered in health equity. And so there were pockets of health equity activities that were taking place inside LDH. And so looking at some of those best practices that were being done, and also looking at, are there health equity policies taking place inside the organization? What are the programmings that are taking place inside the organization? What are the measurements attached to that? And looking at Dr. David Mechanic's targeted interventions tackling racial inequities, resiliency, and enhanced individual and community capacity, I developed a tool that examined what were policies or programming and health equity measurements taking place inside the organization, and as it relates to tackling health inequities, what was taking place inside the organization. As it relates to resiliency interventions, what were those resiliency interventions taking place? As it relates to enhancing individual and community capacity, what were those interventions taking place? And so based on those findings, I was then able to, next slide please, we put together a report which outlined that there were some opportunities that we needed to take advantage of to help improve our health equity response inside the organization. And so we definitely did find opportunities. I didn't call them gaps. I didn't call them shortcomings. I call them opportunities for us, because when you know better, you can do better. And so the opportunities that I found helped to inform our health equity plan. And so it helped to inform the development of the strategies in our plan. And so based on the findings, we put together our strategies. And our strategies indicated, one, for our health equity plan, were to develop a formal plan to operationalize health equity, specific public health best practices throughout the Louisiana Department of Health. Two, create, share, and support and sustain health equity communication and professional development protocols, opportunities, and resources within the Louisiana Department of Health. And three, monitor and evaluate LDH health equity plans, activities, and outcomes. And so those were the strategies that we developed based on the findings, because the findings indicated what was needed. And then two, which is the heart of the health equity plan, were the action steps. Next slide, please. And so this was our plan. And so it's a 35-page document. I think you guys have that access to it as well. And so we have 6 action steps that are outlined in this document. And 3 of them are presently in place inside the organization. Again, the plan was finalized toward the end of 2019. And that plan, you can see inside of it on page 15 and 16, or page 15, of the action steps, the start of the action steps. And so one of the most important things that action steps that is outlined inside the plan is each program office has to develop a health equity action team. Again, as I stated earlier, inside the Office of Public Health, they already had in the STD program and in the Bureau of Family Health, they already had a health equity action team. And so that was one of the best practices that we lift up from there. And we across the board said, this needs to be happening across the agency. And so there was a requirement that asked that all offices create health equity action teams, where on these teams, individuals would look at disparities, needs assessments on an ongoing basis, and make real-time decisions about what should be some of the programmatic changes happening inside the organization. We also made a requirement, because one of the other opportunities that we saw is that demographic data wasn't being looked at, racial data wasn't being looked at on an ongoing basis across the agency. And so that was something that we wanted to make sure that was happening ongoingly, because we know that disparities live there. And so we need to be aware of them. And so what we were able to do inside this plan is to create very specific intentionality around what were those specific activities that needed to take place to help ensure that we see that people are not having the same experiences. And so what then can we do when we are made aware of the fact that people are not having the same experiences? We can report on that, we can put that into a report, and we need to be step away from that report with, okay, what are our next steps? What are our action steps? What are we going to do about this? And so we're creating a culture inside Louisiana Department of Health, where we are bringing the issues to the forefront to say, we've recognized that there's an issue here. Whereas in the past, we might not have been able to as effectively have discussions about that, because these activities were not being done. So we're creating inside the organization a culture where we're looking more on the front end at disparities ongoing, and we're having open conversations about them, and we're training staff about the importance of health equity and social determinants of health while looking at data. And lastly, you can go to the next slide. Part 2 of our phase 2 of our health equity action step. And this is the other level of accountability that we have. We have now established our individuals just received their letters today, the Review, Advise, and Inform Board. And so this board has 2 responsibilities. As I stated earlier, each program office has a health equity action team. That team reports to, they have monthly meetings, and we monitor those meetings. And also, they have an annual report that they send to my office, and that report goes to the secretary, but it also will be going to this body. And this body will do 3 things. It will review, advise, and inform. And so it's another level of accountability for Louisiana Departments of Health equity best practices and protocols that are being done inside the organization. And so we wanted to create a process where we are changing the culture. It is a new business as usual, and diversity and inclusion and health equity are a part of that new business. And so the Review, Advise, and Inform Board will help to review health equity, inform, advise, and inform health equity practices and protocols, while also helping to provide insight and coordination to the state's health assessment and state health improvement plans. Thank you guys so much. I think I might have gone over a little bit, but this is very, very important work to leadership inside the Louisiana Department of Health, knowing that citizens are not all having the same experiences is one of the first things that one can do when trying to ensure that people are achieving their optimal health. I think I might have one more slide, but I think it's just a picture of our webpage. And next, we're going to turn it over to Christopher.
As we wait for the slides to advance. Perfect. Thank my colleagues from Massachusetts and Louisiana and say that I am truly humbled to be part of this panel and to hear the really exciting and impressive work that's going on in both of your states respectively, and the great leadership that you're providing. I first want to say that on behalf of my team at the Department of Health and the Department of Health here in Rhode Island, as well as the communities that we serve, I'm really excited to be able to share both the work that we've been doing over the last 7 years here around the health equity zones, as well as the recently released toolkit that we developed in partnership with Change Lab Solutions, the Robert Wood Johnson Foundation, and our friends at ASTHO. The toolkit really provides a step-by-step outline or framework for replicating the place-based equity initiative that we are doing here in Rhode Island. It doesn't have to be called Hez. You can call it whatever you want. We've heard from some folks that that's not their favorite name or their favorite title, but it really does provide, almost line by line steps of what we've done here in Rhode Island, and really takes you through the kickoff internally and how important it is to do that work internal to your department first. The process of engaging with the community, sort of the tools and resources that you'll need to do that type of engagement, how we've contracted with the partners in the community, the specific requests for proposals and budget frameworks that we're currently using right now, as well as tools for evaluation, training and technical assistance, and sustainability resources that we've identified and processes that we've identified over the last couple of years doing this work. But since the toolkit really provides all of the specifics on how we do that work and what those steps are, I thought I would spend a little bit of time on why and what we're doing behind the scenes and how we got to this point. If you want to skip to the next slide, please. So our current state right now is that we have 11 health equity zones in Rhode Island. Those run the gamut of a small neighborhood in our urban core all the way to one of the largest counties in the state. We are in the process of onboarding an additional 4 health equity zones, as well as a capacity development grant with a grand total of 15 plus a capacity development community. That current state, though, represents over 300 partners who are actively involved and over 850 partners who are tertiarily or sort of on the periphery of the work that happens within the community. And within that collaborative and within that partnership that happens across the state, what's really important is that it's multi-sectoral. It's not just public health practitioners. It's not just folks that are interested in particularly within health outcomes. It really does cut across the multiple different social and environmental sectors that impact community health in the framework of the community. If you want to skip to the next slide, please. So the reason for that is that we understand that that's what makes up 85% of the outcome of the health of the people in our communities. But within that, those social and environmental conditions are not silos in and of themselves. If you are experiencing hunger or you're experiencing barriers to access to food, you are likely also experiencing economic instability that could also be compounded by your proximity to a grocery store or a location that sells affordable, healthy food. So this was a big learning, and it's definitely documented well within the toolkit, that we realized as we started going down this road that it wasn't enough to target a social and environmental condition. It wasn't enough to just say, we want to do this equity-based work. We had to think differently about how we invested as a state and what we were investing in and what our priorities were. And the other side of that is how we approach addressing the needs within the community and making change to those needs. We love the river framework. And it really, because it creates a situation where we don't get into this, mutually exclusive debate of how can we address the upstream. We have to eliminate, the downstream service delivery piece. Well, no, right? They're not mutually exclusive. They're mutually beneficial, and they both need to be happening at the same time within the community. And in between that, there needs to be a coordination of both the services and then understanding how those services are being delivered based on the needs within the community to help inform right-sized interventions at the upstream, within the upstream change realm. And within that sort of contextual framework, what we really recognize at the sort of end of one iteration of our community investing and beginning of the health equity zones was you need a commensurate, framework and infrastructure at the community level to do this work in a meaningful way. So what Hez really represents is our efforts to create, a meaningful investment into the community that is based on building, a community framework that moves us from just transactional interaction to transformational change at the community level. And if you can skip to the next slide, please. The way that we do that is using the Hez framework and the community-led foundation that it represents. And there are 5 steps within that framework that we found have been essential. It has expanded, it has contracted a little bit, but we always sort of land on these 5 things that really need to happen. And they all happen within basically the first year of our contracting with the community or our working with the community. The first is really with the community. And we are agnostic about the geographic location, other than in the sense to say that there needs to be at least 5,000 people who will be served so that we can see some measurable benefit, that it's contiguous, and that there's some level of equity need or disparity need. And I love Dr. Benjamin Robbins' comment about equity is not just a black and white thing, right? There are rural communities that have significant concerns and challenges. And those communities coming together to say, look, this is what we want to work on we think sort of a fundamental building block. Because if we assign to the community, this is where you're going to work, it no longer is led by the community. The second step there is to build a collaborative. That sounds pretty simple, but it tends to be a lot of work. The third is to conduct an assessment, not just of the needs and the barriers and the challenges, as we always do, but really think about who are the players, who are there, who's there helping right now. Prioritize in partnership with the community what's important, what things are going well, what things need to be changed. And then the final piece in this, which is really the most important, is to develop a formal plan of action. And that formal plan of action serves as the foundation for all of the work that we begin to do with those community partners. And as you can see below, throughout this process, we both require and reinforce continuous community engagement. So each of these steps needs to have the community involved, not just the leaders in the community, not just the grass tops, but the grassroots. The community has to vet and approve and support of the plan that is illustrated or provided by the community. Next slide, please. So why, and what does this do for us, and how does it lead to transformational change? Well, the first is that we understand that by investing in sustainable community infrastructure, we're changing the framework and we're changing the way that the community interacts together. But we also understand that without that framework, without that structure at the community level that is providing a plan and a path forward, we're always going to be doing top-down siloed intervention and siloed investment. So the next step in that, after we've worked with the community and we continue to work with the community to both develop and reinforce the community infrastructure, is to really work as the state to right the ship, right? To put the cart back behind the horse, whatever metaphor you want to use. And the rationale for that, or the reality is, we're trying to have the community set this foundation to say, here's what our needs are. When we say, oh, we want to improve housing in this particular zip code because look, we see all these disparities and we see all these negative outcomes, and these are the problems that we as the state want to solve from our offices. We're not listening to the community. We don't understand what the nuances and the things that need to be invested in. So what that plan allows us to do is to give the community the space and the time with, agnostic to the funding stream, to come up with a plan of what's important and what needs to change. And then we work in partnership with those folks to bring the right resources to the community to address the needs that they've identified in ways that are appropriate to the people within that place. The last piece of that is really focused on, I think, a lot of what's been talked about today, which is better understanding how to create data systems to measure impact and changing the narrative about sort of programmatic, particular disease-based outcomes being what drives success to being what the community is defined as what's important to them is what our success metrics are. And that's a whole journey that we're still on. I don't want to say that we've arrived, but we're definitely working towards it. Next slide, please. So what do these look like? And taking it out of the abstract of here's a community collaborative and putting it into something more specific. Providence is the largest metropolitan area in the state of Rhode Island. It's dwarfed in comparison to my two colleague states, but still it's the largest city that we have in Rhode Island. And these are the different partners that are working right now in the central part of the city to come together to address the social and environmental conditions and healthcare conditions of their community. These are the partners that have stepped forward. And then within that is the really central table where those folks convene as the health equity zone. It's important to call out that not all of these sectors come together every single month to meet as a collective group, but they have a series of priorities that are tied to these particular domains that these colleagues work not just within their silo, but connected all throughout this system. So that as we're trying to change things around economic development, there will be interactions between education and the economic development sector. Next slide, please. I wanted to touch briefly just on what we're all dealing with and the reality and how this has changed during the time of COVID. We have engaged very deliberately and intensely with our partners in the community. These collaboratives and this infrastructure that we have invested in the community presents a unique opportunity for us to get down into the communities that are being most disproportionately impacted. So to date, we've invested somewhere in the vicinity in total, actually about $14.5 million in testing, vaccination, and community outreach strategies, really isolated on this concept of the faster we get to the people who are being disproportionately impacted and support their needs, the less spread that we're going to have. Next slide, please. This is just a quick overview of some of the things that we've achieved over the last 6 months of the response. In partnership with our partners in the community. For context, there's only about 1 million people here in Rhode Island. So this gives you an idea of the scale of the response that we've outlined in partnership with the community. I also want to add that we've hired and onboarded over 100 community outreach specialists and community health workers as part of this response. And those are folks from the community that either became unemployed or were underemployed at the time of the pandemic outbreak. And then next slide will be my final. I just want to thank our partners in this work, Change Lab Solutions, Robert Wood Johnson Foundation, and ASTHO, who have supported us in developing the toolkit. But I also want to thank our partners in the community because they are the ones who do the work every day. Thanks so much.
Thank you to all of our presenters. I know that was, a fast, a whirlwind tour of all the work that's being done in these states. And there have been a lot of questions, which I'm glad for. I'm going to say up front, we probably won't get to all of them because there are quite a few. But if our leadership team can kind of corral some of those that weren't answered, and if we can send those out electronically to those presenters to give a personal response for that question, I think the ones that have asked would be happy. So I'm going to start with Dr. Monica, to Dr. Burrell. It says, when you became the Massachusetts State Health Equity official, you developed a framework that used data to talk about disparities in your state. And you've expanded on focusing upstream, addressing the root causes. How have you involved other sectors like housing and the economic and transportation and partnering with all of those other agencies?
Yes, Vivian, thank you so much. And related to the Q&A, I think some of us have been answering as we go. So a couple of things that I could put in. So for those of you who asked questions, if you go back to the Q&A, there are some answers there.
Thank you.
The short answer to your question is yes. Our work, as we know, is health in all policies. We've worked with transportation for things like safer streets. We work actually across our executive office in Health and Human Services. We have a regular meeting that is called an Interagency Health Equity Task Force. And through that work, we look at assisting other agencies, whether it's Department of Children and Families or Departments of Transitional Assistance or Massachusetts Medicaid, in order to your point, look at data and focus on health inequities and how to target resources. So thank you so much for that question.
Great. So this next question is for Dr. Robinson. It says, your health equity strategy and framework is very comprehensive, and it focuses on community engagement. How did community members influence that framework? And what was the most surprising thing you learned about engaging communities while you were developing this tool? You're on mute, Dr. Benjamin Robinson.
I come from a community engagement background, so probably didn't learn anything surprising. And so the community did not have a strong role to play in the development of that plan. What we did was the staff inside the organization, I had leadership identify individuals from their teams, and those team members came together and to help to shape the plan itself. And so, so that's who more or less helped shape that plan. But via my many years of community engagement experience, I knew what should be some of the best practices that needed to be inside that plan. And so, and based on the findings of that initial assessment that we did with staff inside the organization, we found that there were opportunities where across the board, some of the offices needed to have relationship with community. And so inside the community engagement plan, which is probably the biggest piece of the health equity plan, there are 21 action steps. And of those 21 action steps, the offices get to choose 11 activities that they can be involved in relationship with community, because relationship with community is key. We have to get out of this idea that, oh, I'm just only here to provide condoms, or I'm just only here to give a pamphlet, or I'm only here to give someone a shot. COVID has taught us, there's a tremendous amount of vaccine hesitancy right now. And some of that hesitancy has to do with historical racism, misogyny, and other isms. And some of it has to do with the fact that we haven't had good relationship with community. And so had we had good relationship with community before COVID happened, I don't believe that we would have as much hesitancy as we're having. Our communities would be more open to listening to some of the information that we have coming from our health departments. That doesn't take away the fact that a lot of individuals are listening to health department officials, but we must be honest and say that there is a tremendous amount of vaccine hesitancy. And when you have better relationships with community, people are more likely to listen to you and take what you have as truth. And so having a great relationship with community, if you are running a state agency, that has to be one of your key things. That has to be a priority. You have to have a relationship with community.
I agree. So I'm going to let, sorry.
I wanted to echo really quickly on what Dr. Benjamin Robinson said. I was struck by, there's some parallels across all three of our presentations, even though we're doing it in different states, the work in different states. And one of the most powerful to me from our presentations was this concept of community engagement. And all of our work is better if we engage the community. So many community members in my own community engagement work say, you're throwing answers at us, but you're not asking the right questions, right? So even for people who are well intentioned, if we don't engage the community in a meaningful way, right? A meaningful way, we're not going to solve the problems, and we're going to be running in those circles. So I really appreciate those concepts, Dr. Benjamin Robinson. And the other thing that you mentioned about vaccine hesitancy, when I talk to individuals, they say vaccine hesitancy doesn't mean no. It says, I am asking you to give me facts and answer questions that I have so that I can make an informed decision. And all of us would want that.
Mm-hmm.
Yeah. So I'm going to turn the last question to Christopher, and I'm going to ask him, you talked about your health equity zones and how important that is to communities. has a community or ever had any conflict with what you were proposing or what you visioned and what that community visioned as a health equity zone? And how did you come together for a shared vision or create a shared plan?
Boy, have they ever. I would say that they have not just, we continue to. It is a part of the work, right? And we really take a restorative justice framework with the work that we do, and recognizing that there's a lot of community trauma that's not necessarily us. It's not our, it's not that we personally or even we as the department have created the issue. There's also a lot of institutional systems that we are responsible for that quite frankly need to change. We have taken the tack, and I would say the primary success that we've achieved is creating a meaningful relationship with these partners, where when something isn't going right, we stop acting as the funder and we start acting as a partner. And that has been really hard to do, but has been transformational in the work. We refer to that very frequently as moving past compliance-based contracting and compliance-based relationships into a really intentional alignment and collaborative partnership with those folks in the community. I mean, COVID's a great example of where we got a lot of pushback and a lot of frustration from the community saying, you promised to us this was not going to be top down. And here you are, the health department, saying, here are the mitigation techniques. Here's what you're going to do. You're going to distribute these masks. We're going to, set up testing locations in these locations. That was hard, and we just had to own it. We had to be really honest with the community and say, we get it. We agree with you. This is top down, and it's, we're going to work towards making it not top down. But I will say that, that framework of us giving the community, dollars that are not tied to one particular outcome, letting them come up with that strategy and say that this is what's important to us, and then actually coming back to the table with money that's not our money. Like, we bring housing folks to the table. We bring economic development to the table. We bring, the planning folks to the table, and we use our power as a department and, sort of our relationships to the department to help facilitate that. And the community takes notice. It doesn't always go great. I get a lot of phone calls at 7 o'clock at night with people very fired up, but that's all right. That's the job. And,
Right.
that's just me, that's my entire team. So we're always there, and we keep, an open line of communication between us and the community. And we keep it as honest as we possibly can.
I think we'll close with that. I think you hit it on the head, and that's being transparent and being honest with our communities of what we can and cannot do, and what we value from them, right? We value their input, and that we're going to start being more active listeners, right? And let them tell us what they need versus population health telling them, we think you need this, which we've done historically as public health professionals. So I thank you all for your time. I thank you guys for tuning in this afternoon. I think this has been very, very, very helpful. I've learned a lot. I'm going to be reaching out personally myself to some of our presenters today, because I think we can still learn from each other. We don't know it all. So I'm always looking for best practices. So thank you very much.
Thank you.